I think CAR-T cells are a really exciting area in myeloma, and as we saw from the recent paper in the New England Journal, the response rates are actually quite high, over 90%. And unlike what we saw with CD19-directed CAR-T cells in lymphoma and ALL, the cytokine release syndrome, or CRS, seems to be much lower in myeloma than we saw in those other diseases. And whether that's just target specificity, that BCMA is a more unique target for myeloma than CD19 is in ALL or lymphoma, I don't know the answer to that. But certainly from a safety perspective, it looks quite reasonable. I think what we also have seen is that the durability of those responses do not appear to match up to the durability of what we've seen in ALL and lymphoma, in that the number of long-term remitters appears to be lower than one would like. And I think the take-home messages really are twofold. The first is, this is our first real experience with CAR-T cells in myeloma, and I think we need to better understand how to optimize long-term duration and how to choose patients that may have T cells that will be most effective in the long term. The second is, are there things we can do to enhance the efficacy of CAR-T cells even after they've been given? And maybe that's strategies such as PD-1 blockade, or immunomodulatory approaches with lenalidomide or pomalidomide, or other strategies to try and make them last longer, ultimately improving responses.